Hi, good evening. I'm Dr. Philip McMillan. Thank you for joining me as I take a look at what I consider an unnecessary amount of deaths that have occurred across the pandemic, but also within the vaccinated cohort. And there's a reason why I'm focusing on this, and it's because of a recent paper that has been published, which shows in a specific cohort of high risk males that there is clear benefit for them being vaccinated, certainly at the time before Omicron or even around Omicron and Delta. So I'll be going to take a quick look at that paper. But I'm asking a far more important question. And what is concerning me is that the whole system put all their eggs in one basket, and that's the vaccination basket. And it didn't seem as though the medical and the scientific community were willing to find any other solutions. Everything was about this is what we've got to do. And the paper will show that there was benefit. But I am concerned that good is the enemy of best. We could have done so much better. And the reason I say that is because I have had the pleasure or the privilege of speaking with clinicians across the world, and some have had absolutely outstanding results by using very simple strategies early on in the disease. And I think that we need to reflect carefully on where we are, look objectively at data. And I've found that too many people are in the black and white. Something is either good or it's not, or it has no benefit or it has all the benefit. And you have these camps that are unable to recognize the nuances that exist within that. You can have benefit and you can have risk. If you use something in the right way, you will have the most benefit and the least risk. That has always been my concern with the pandemic. I've always believed in targeted vaccination, and I think the paper is likely to support what it was that I was thinking about earlier on in the pandemic and even now. But before I start, I'd like to encourage you all, if you want to continue hearing about these kinds of things, I want you to join with me on this Wealth, Health, and Wellness Network. We're going to have our first session coming up this Thursday. And what I realize I need to do, because this is what people seem to be quite interested in, is that they want to understand what's happening. And so, as usual, my focus is COVID storm. And the storm is what I predict is happening at the moment, spike triggered autoimmune response mechanism. And it's happening in multiple organs across the body. And the question is, how does the pathology present? And so, this is an exploration in the science that I'm doing. So, what I'll be doing in these sessions is taking you through different aspects of it and discussing different mechanisms and ways that we can possibly manage that. Additionally, what I want you to do is that I want you to join us in our latest Kickstarter program. And it's about Are You Prepared for Disease X? We've been planning this for a long time. And finally, we're getting it together. And we want your support. And if you want this book, what you have to do is make sure that you sign up for the newsletter and join the Kickstarter. So it's two signups that you have to do. So once you've subscribed, it will then take you to our Kickstarter page where you will then get the opportunity to both click on you're not purchasing if you click on this. This is just so that you can be notified about when it's launched. And critically, you will get this free promotional ebook. This is really the gift that we're giving you just because we want you to subscribe. And so this is a fascinating piece of work. As you know, I work alongside, I collaborate with Lumientia, and so we have looked at this, and he's done some remarkable work here. And this is essentially capturing the research about the capital conversations with medical experts and Ron Johnson. And it has here all the people who were involved in some of these things. And so what this is just some excerpts of essentially what was covered in that period of time, February 28th, 2024. It is a huge discussion, a panel discussion, but what we've been able to do is that we've been able to pull and summarize what each speaker was saying. That's Senator Ron Johnson. He's talking about the deaths and so on. They have Robert Malone. Look at the imagery as well. So this is free, and we want you to join us with regards to this. This is the gift for you joining the newsletter. So yes, we want you to join with us. It's free. Come along with the journey. Let's look at the science, and you'll find the link in the description. But let's get back to what was happening with regards to the science. It's a very important paper that was recently published, and I'll show you here. This paper here was published on the 17th of July, 2024. So it's just recently published. And they're actually talking about post-acute sequelae of SARS-CoV-2 infection in the pre-Delta, Delta, and Omicron eras. Now, the first thing I'll say is that whenever people speak about this is theoretically the long COVID discussion. And what I have said, because it's an area that I've been focused on for a long time, is that when you speak about long COVID, my view and my research has told me that you need to separate the cohorts. There are people who've had severe, moderate, and severe COVID 19, and that's primarily an autoimmune cytokine kind of response. And you can have organ damage associated with it. And so, with that organ damage, you can have longer term health effects. I separate that from pure long COVID in my mind, where someone has had a mild infection and they end up with long term symptoms. This can also happen with vaccination. And some people think it only happens with vaccination. No, it happens both in both cohorts. We still are trying to work on the mechanism that causes it. But the point is I tend to separate it because I think the primary pathophysiology is slightly different. There is some overlap, but they seem to be different. And so, what they're talking about in this paper here is that they are looking primarily at the post severe, moderate to severe conditions in patients after the pandemic or through the infection. They covered a big period of time, March 1st, 2020 to January 31st, 2022, looking at about 4.7 million people, including controls. And the study population was about 441 veterans. I'm going to come back to this in a minute, but you must remember that these are veterans. But here is the bit that this is what the paper was pushing as a very important. When they looked at PASC during the first year of infection, 10.42 events per 100 persons. And essentially, they were comparing that among that. This was the unvaccinated, and among the vaccinated persons, it was about 5.34 events per 100 persons. So this is like a 50% difference in terms of the benefit from the vaccination program. And this was a good study in the sense that it went looking. And so normally what they sometimes do is that they will cover vaccination from 2 weeks after the second vaccine. In this case, they actually seem to have covered it from any dose of the vaccine, which is essentially what you should be doing when you're trying to look at outcomes and adverse outcomes as well. And so, what's very quickly happening is that we're seeing more and more papers coming out quite recently that are reinforcing that the decision about vaccines and vaccine mandates were correct. As you know, I completely disagree with that. What I had always said was that at the beginning of the pandemic, or when the vaccines came out, and I was coming through an autoimmune paradigm, meaning that my research had suggested that the cytokine storm was an autoimmune response triggered by the virus. And so what I was saying is that this is an overreaction of the immune system. And so therefore you have to be very careful about priming the immune system with regards to vaccination. That was my perspective. And so with that in mind, my view was that you use it on the cohort that you know are at severe risk. And who is that? And this is where it comes back to the paper. It's always useful to look at the supplementary report here, and there is a section in it where it breaks it down to make sure that I've got it right. I'm trying to see if I can make sure I've got the bit that I want you to look at, but it breaks it down by age group. And essentially, when you look at the age group here, is that the age group was about 63 years old. Okay. I want you to see it so that you'll know that I'm not making this up. I've got it here. I'll just make this a bit bigger here. So this is what it looked like here. So this was from the supplementary report, and they were looking at the baseline characteristics of the overall cohort. And you can see here the mean age was 63.98 years in terms of age. So technically 64 years old. So this is, and if you go down in terms of sex, you can notice here male sex was 90.55. So the majority, the vast majority were males, and their average age was about 64. The reason I highlight that is largely because when we looked at severe COVID 19, we knew who the high risk was. It was older males. And actually, when you look at the breakdown of severe COVID 19, it is 60% men, 40% women. So men are at much higher risk than women. Then, when you add age onto it, absolutely, this was the highest risk cohort. And so, encouraging that cohort to be vaccinated at the time, if, as far as I'm concerned, they weren't previously exposed to the virus, because if they already had natural immunity, as far as I'm concerned, why would you vaccinate them? That's where the question of hybrid immunity comes up. I'll not get into that, other than to say that the immune system is like the clotting system. If you clot too much, it causes problems. If you clot too little, you end up with bleeding, and it's a balance. It's the same with the immune system. If you have poor immunity, you end up with recurrent infections. If you have overactive immunity, you have autoimmune diseases. So what you want is the immune system to respond, but just right. Stop when it needs to stop. And so my point was that by overstimulating the immune system, it can't, in the long run, have a beneficial effect. So I have never stood by the concept of hybrid immunity. Now, the scientific community can disagree with me on it, but I think more and more what we're seeing with recurrent infection and autoimmune responses, this is probably going to be borne out as being extremely important. Now, when it comes down to the question of how many deaths is too many, I'll try and explain this from the data. So I'm going to show you the data here again so that you can look at it in terms of the breakdown. So this was the whole cohort, the COVID-19 cohorts. They're looking at about 499,000, so almost 500,000 people who had used the Veterans Healthcare System. And they had it broken down where T0 is where the person had an infection. So you have the pre-Delta region era, then you had the Delta era, then you had the Omicron era. Okay. Now, what I was highlighting is that when you look down here and you look at this, was the bit that I found very interesting. So this is where I'm focused on. And this is within 30 days of infection. So they're looking at how many people were alive within 30 days of infection. And you have to remember, severe COVID 19 would tend to present at around day 10. And if you either survive or you don't survive in that period of time, most deaths would have happened by about 30 days, some extended for longer. You can see here when they look at the unvaccinated cohort, which is 57,247, you can see that they had 54,000 were still alive. So they lost about 3,000 people by 30 days. You compare that in the vaccinated cohort in Delta, it went from 58,090 to 56 to 60. So they still lost about 1,000, maybe 800 or 700 people in that period of 30 days. And in the Omicron period, it went down for both cohorts. So for this period, when I looked at the numbers for the unvaccinated, it was about 5.7% mortality in this high risk 64-year-old male cohort primarily. And it was about 3.2% in the vaccinated cohort. So this is where it shows that in this high risk group, the vaccine could reduce mortality by almost half, which is very good. Similar thing here, 3% to 1.4% in the Omicron era. But as I highlighted to you, this, in my mind, is still too many deaths. Because you have to remember that this was sold that if people were vaccinated, that's all they needed to do to prevent deaths. It wasn't put across that this is there to reduce mortality. Now, the reason that that's important is when I pull back from it and I reflect on what messages should come across from public health. I'll give you an analogy then to help you to understand what I'm thinking about. It would be like finding that people are having strokes. You know that there is an association with an irregular heartbeat, atrial fibrillation. So, what you then do is everybody who is found to have atrial fibrillation, you put them on medication, a blood thinner, but then you stop. You're not interested in their blood pressure. You're not interested in their weight. You're not interested in their lifestyle, whether they smoke or anything else. And you just leave it at that. And that's all you do. You will get an improvement in terms of strokes, but you would not have optimized the risk for each individual. That's the way that I look at what they have done here. There is certainly in the high risk cohort improvement, but could they have done more? What about all the other things that were available? And now you have to remember, I come from expecting a very high standard. Can you imagine looking at these numbers and thinking that, gosh, even in the vaccinated cohort, over 1,700 people died from severe COVID 19? What's the mechanism? What was the pathology? Is it the same as what happened with the unvaccinated? All of these questions were not answered. And I happen to know clinicians in different parts of the world that had almost zero mortality using strategies very early on before patients came to hospital. And this is what I mean. Imagine if we really tried in that every conceivable option that was even partially workable, anything that worked, anything that helped, you used it, along with the fact that people who were in the high risk, you still vaccinated them. That would have been the way to get the best outcomes. And that would have been reasonable. That was actually the aim. What happened? I remember when they started to go down the age group with regards to vaccination, and they were going step by step. First, the high risk. We knew who they were. They all got vaccinated. Then they started to go down the line. Then they started to target younger and younger people. Then they decided to mandate it so that working age people had to take it. That made no logical sense when you knew who the high risk were. That's where my view is that they got caught up in the politics and the financial benefit. And they overextended the use where there would not be as much benefit. Because the kind of benefit, the kind of mortality that you are seeing in the 64-year-old men would nowhere near be at all anything in a 25-year-old woman who had no comorbidities. It would be chalk and cheese, and this is what even the Oxford had created a risk score, and you could see a humongous difference based on age and comorbidities. We knew exactly who was high risk. That's now where they need to now do the next bit of the study. And if they don't do this, then I know they're really just pushing a narrative, which is that you have demonstrated the benefit in the high risk group for vaccination. Now, what you need to do is you need to take the low risk cohorts. And this time it's not 30 days. You need to monitor them for, say, a year. What outcomes did they have? Did they have any adverse effects? What was the risk benefit for the low risk cohorts? That now is also extremely valuable. Now, it may damage a narrative and it may increase liability for some people, but there is no way that you can rebuild trust if that kind of research is not done. We are in difficult times, and I understand that it would be ideal to sweep it under the carpet and move on. But it doesn't answer the questions and it doesn't address all of the concerns that the public has. And it doesn't deal with the fact that many people who had adverse effects are not aware or don't understand the longer term risks. So, in summary, what we've got here, I believe that targeted vaccination to high risk groups, men and women, older, with comorbidities, including obesity, even younger children who had comorbidities that would put them at risk of more severe disease, that's completely reasonable. However, I am still yet to be convinced that carrying this benefit that you are seeing, and this is what is happening, people extrapolate that benefit in the older male cohort to assume this is the same for a 20-year-old woman. That is not logical, it's not scientific, and it certainly is not clinical medicine. So the principle is we could have done much better. I think that there were benefits, but the benefits could have been even significantly higher if we had used all the resources that were available. And you know what I find interesting is if they had done just a simple strategy with the unvaccinated cohort of men. Imagine if they had just given every one of them 100,000 100,000 units of vitamin D. I wonder, would that have had further impacts on outcomes? That's the kind of question, that's the kind of answer that we should have been having at this time and at that time, and we still need answers for. Have a great evening. And remember, as I said, I want you to join us in this process. Join me in the webinar coming up on Thursday this week. We'll be talking about storm and the related things. I want you to go to the landing page. Make sure you register for Disease X and you get the free ebook, Capital COVID Conversations. That's our gift to you. So join us in this journey of science. We ask hard questions. We don't follow a narrative. We just try and find the best answers for you and your loved ones as best as we can. Have a great evening.